everyone. I'll be presenting on my summer project today, which explored the patient-borne costs and wait times for care of obstructive sleep apnea in rural and urban populations in Alberta. So before I begin, I'm just going to go through a little bit of the background. Obstructive sleep apnea is a common chronic condition. It increases the risk of motor vehicle crashes, depression, high blood pressure, and cardiovascular disease. In Alberta, moderate to severe OSA is commonly treated with continuous positive airway pressure, CPAP, which is provided by respiratory home care companies with a prescription. The cost of CPAP therapy is typically borne by the patient, either out of pocket or through private insurance, with government funding being available for patients of low-income groups. An increasingly recognized barrier to the diagnosis and treatment of chronic diseases such as obstructive sleep apnea is geography, yet no prior studies have investigated the influence of place of residence on the patient-borne costs and wait times for OSA care. So the following study's objective was to determine if there are differences in wait times and costs for OSA diagnosis and treatment between participants with rural or urban residences. Adults aged 18 years or older who initiated CPAP treatment for uncomplicated OSA that was diagnosed by a physician using specialist interpreted diagnostic testing were recruited to participate in the study. Participants' residential postal codes were translated into geographic census areas, and participants were classified as having either an urban or rural residence. A wait times and cost of OSA care questionnaire was also developed and administered at baseline and at 3 months of therapy. Domains of inquiry included wait times and travel distance, patient-borne costs, and absenteeism due to OSA symptoms. The following study takes on an embedded mixed methods design approach. It primarily uses quantitative data retrieved from a survey and qualitative data from open-ended questions within the survey, which are later transformed into numerical categorical data. Descriptive statistics were then used to report study participants' baseline characteristics, including participant demographics and OSA severity, and questionnaire data in each study group. Study outcomes are still continuing to be analyzed and may include further statistical analyses on some domains in the questionnaire. Of the 253 recruited patients, 242 were enrolled in the study. 142 individuals were classified as having an urban residence, and 100 individuals were classified as having a rural residence. The mean age of participants was 51 years old, and the mean body mass index was 34 kilograms meters squared. Individuals in the rural cohort had lower median household income and traveled a greater distance for diagnosis and treatment. The main results are still being analyzed and interpreted, so I can't speak too much on it at the moment, but we did find that individuals with a rural residence paid more out of pocket or through private insurance than individuals with an urban residence for diagnostic testing and CPAP therapy. The proportion of wait time from first assessment to diagnosis and time from diagnosis to treatment was similar in both cohorts. From first assessment, 77% of urban and 65% of rural respondents reported a wait time of 4 weeks or under for diagnosis. From diagnosis to treatment, 72% urban respondents and 59% rural respondents reported a wait time of 4 weeks or under. Despite there being small differences in wait times between the two cohorts, we did see a greater proportion of rural participants reporting their perception of the wait times for care to be too long. There were also very few urban and rural respondents that reported absenteeism due to OSA symptoms, with very small differences between the two groups. Wait times for care are similar between rural and urban patients with uncomplicated OSA, but costs of care may be slightly higher for individuals from rural settings. So differing perspectives on the quality of care could be managed through system improvements or more information for patients about expectations of care. I worked on the following project with Ada and Dr. Pinharker, and my role was to conduct descriptive statistics to analyze and interpret the study data. I'm currently working to synthesize a manuscript based upon the study findings and include the relevant research gathered in the area. My main takeaway is that using Excel is hard, and that no matter how efficiently you think you're analyzing and managing your data, there's almost always a shortcut that could save so much time, and not to mention the frustration. Also, with this being my first research project, including manuscript preparation and writing, I've also learned that developing and preparing a manuscript takes some time as we work to synthesize the data and piece together the results to amplify the central message of the research. There's a lot of back and forth as new interpretations change the way we want to present the results, and as I experienced this, I realized there was room for creativity and that I really enjoyed the process. Now, in terms of the next steps for the project, the next steps are to revisit and finish some of the data analyses and discuss the implications of the statistical findings, as well as the future avenues of research. This concludes my presentation. Thank you so much for listening.